Okay, welcome to this video on clinical reasoning. Now we're going to talk about Bayesian reasoning, and we're not going to talk about it from a mathematical standpoint with equations. We're just going to talk about it conceptually. And it falls under the area here of prioritizing a differential diagnosis. Given some information and a test result, you need to now create in a new probability about whether you think this, that gives you the information to say whether you want to trash a diagnosis, treat it, or you need more information, you want to test it. Okay, and we're going to start here with some take-home points, and I think these are important. And the most important point is that your pre-test probability matters. Where you start from matters. We start with an estimate of disease, and that's called our pre-test probability or prior probability. When we have no other information about this patient, we can just ask what is the prevalence of disease in that population, and that prevalence can be our starting point. Now, positive tests are going to raise our probability from that starting point, and negative tests are going to decrease our probability from that starting point. And how far it raises or lowers it from that starting point is based on the sensitivity and specificity. And so here we have a example, right? And so here's a patient with a pretest probability of a disease of about 32%, right? And our goal is then to see what happens when we have a positive test. It's going to raise that probability sum. And a negative test is going to do the opposite. It's going to lower that probability sum, right? And how much does it do it? It's different for different tests, right? So here we have two tests, test A and test B. Test B lowers the probability when it's negative a lot more than A. Test A doesn't do such a hot job there. Now we can look at when a test is positive, right? Here, test A does much better, right? When it's positive, it raises the probability much higher than test B raises the probability from our initial starting point, which is our pretest probability. And so so a test can perform differently when it's positive and when it's negative, right? In this example we showed, test A here is orange with this dotted line, and we see that test A did really well when it's positive and not so hot when it was negative. And test B did the opposite. It performed really well when it was negative and not so well when it was positive, right? So we could say that test A is more specific than test B, right? And test B is more sensitive than test A. And if we think back to our pig and spinning and snout, right? Sensitivity or specificity positive helps you rule in a disease. So when you have a positive test, a high specificity is going to help you rule in a disease because it's going to help you raise that probability more. And the opposite for this, sensitivity, negative, rule out. So when you have a negative test, a high sensitivity is going to lower the probability more and help you rule out a disease. And so where you start from matters, though. And so we're going to talk about that here. We got 3 different pretest probabilities, and we're going to apply the same test to it. And in this case, we'll just say it's positive, right? So in this test, the test is positive, and we started from about, let's say, I don't know, maybe 4%, and we went up to about 26%, let's say. And that was not enough. We started out in the trash it zone, and we ended up in the trash it zone. It wasn't enough to change our decision. In fact, this test didn't change management at all and should not have been ordered in the first place. Let's do the same exact test now with this person who had a pretest probability of 32 and it raised it to about 57, right? So we started off in the I don't know zone and we ended up in the I don't know zone. So again, this test did not help us. It did not change management because the test wasn't good enough to bump us up from where we started. We started off with this pretest probability. We did go up, but not enough. Let's look at this third one. So the third one has a pretest probability of maybe 60%, and we bump it up to about 85%. So this test did move us from the I don't know zone to the treated zone. And so that test was worth ordering. Now we have a saying, when you hear hoofbeats, think horses and not zebras. And what that means is that always think about the common diseases first. Common diseases are common. Rare diseases are not common. No matter how classic the description of this patient's presentation is and how much it fits this rare disease, it's more likely that it's something that's common, right? So positive tests in very rare diseases doesn't mean they have that disease. In fact, what it really means, it's more likely that the test is wrong, right? And then they have that disease, that you actually have a false positive. And so these base rates do matter. In rare diseases, we have to be very careful. Let's look at it a different way, okay? And we're going to, again, still talking about base rates, and this is base rate neglect, which is from Amos Tversky and Daniel Kahneman. And you can read about this in their great book, Thinking Fast and Slow. And they describe this gentleman, Tom. He's of high intelligence, lacking in creativity, has a need for order and clarity. His writing is dull and mechanical, strong drive for competence, not much sympathy, doesn't like interacting with others. And you're asked, is he more likely to be a humanities major or a computer science major? This is an old example, okay? So this is a very stereotypical description. I think that does not necessarily apply, but for the sake of this, let's pretend that it does. And most people say that this is a description of a computer science major, and they would say he's a computer science major. But what if I told you that there are 250 humanities majors for every one computer science major in that college? That's the base rate. You know that it's way more common to be a humanities major than it is a computer science major. So no matter how classic this description is, it's still pretty likely that he's a humanities major, just one who is much more of an introvert. And so the same thing can be done with diseases, right? So if Tom has a classic presentation of a very, very rare disease, how likely is it that he has that rare disease? Again, it's pretty unlikely because that disease is pretty rare, no matter how classic the description or positive the test, right? You have to remember what that base rate is, what that pretest probability is. You have to remember from where you started. Okay. And so that's what's important. Your impression, your initial impression matters because that's where you are going to go up and down from. So let's look at this in a different way, okay? This is a box diagram that's commonly used to demonstrate pretest or Bayesian reasoning. And so this box represents 100 people, let's say, okay? And so 20% of the people have the disease and 80% of the people don't have the disease. And that means that there's a prevalence of the disease of 20% in the population, right? So that's where we're starting. That's our pretest probability or prior probability. So for every 2 people with the disease, there are 8 people who don't have the disease. Now we have a test. And this test has these characteristics. It has a sensitivity of 80% and a specificity of 80%. What does that mean? Sensitivity of 80%. Of all the people who have the disease, how many of them are going to have a positive test? 80%. That's what this means. So there are going to be 80% of the people who have the disease with a positive test. That means there are people over here who have a negative test, right? And what about specificity? That says, of all the people who don't have the disease, how many of them are going to have a negative test? 80%. And that means all of these people are without the disease and they have a negative test, and that means that there are people with the disease who had a positive test, right? Incorrectly so, and that's this area here. And now we have to ask ourselves, what is the probability that our person has a disease given this test, right? So we have 80% of the 80 people with this sensitivity and specificity, right? With a positive test, 80% of the people with the disease are going to have it, and 20% of them without the disease are going to have a positive test. So now let's put that together, right? We said that our pretest probability was 2 people. There are 2 people with the disease for every 8 without the disease. And then our sensitivity and specificity gave us that there are 80 positive tests in people with the disease for every, and there's 20 positive tests for every patient in patients who don't have the disease, right? So if you then do the math, you have 160 to 160, so that's a 1-to-1 ratio, which comes out to 50%. So what that means now is our patient with a positive test, has a 50% chance of having this disease, right? We raised our probability from 20 to 50. Now, let's lower that pretest probability some, okay? So let's say that it's now 10%. Maybe the prevalence of that disease was 10%, right? So for every 1 person with the disease, there are 9 people who don't have the disease. And we're going to use the same testing characteristics as well. So that means that for everyone who in people who have the disease, a positive test, right? The 80% of them are going to have a positive test. And in people who don't have the disease, 20% of them are going to have a positive test. So what happens now to our probabilities? We have that same before, right? 80% of the 80 people for the disease are going to have the disease, are going to have a positive test, and 20 people without the disease are going to have a positive test, except now we've changed our prior probabilities from from 2 to 8 to 1 to 9, right? So that's 80 people with the disease are going to have a positive test, and 180 without the disease, I should say, no disease. And that comes up to 30%. All right, so we now, starting at a lower probability, we raised our probability from 10% to 30% because our pretest probability started off lower. Remember, before we went from 20% to 50% when we started at a prevalence of 20. We started off with a pretest probability of 20, and now we're starting off at 10, and we went to 30. Now what happens? Okay, so now our probability of disease in our patient is 30%, so let's update our model, right? So now we're going to raise this to 30%. So now there's a 30% chance that they have the disease and a 70% chance that they don't have the disease. All right, so we have a new base rate now. It's 30%, so there are 3 people with the disease for every 7 that don't have the disease. And we're going to use now a new test with new testing characteristics. All right, and this one has a sensitivity of 90% and a specificity of 80%. And that means of all the people who have the disease, 90% of them are going to have a positive test. And of all the people who don't have the disease, 20% of them are going to have a positive test. Right? And so we could say 90 positive tests for those with disease and 20 positive tests for those with no disease. And again, we do the same thing. 3 to 7 was our pretest probability. 90 to 20 is our testing characteristics, so that gets us 270 positive tests in those with the disease, 140 positive tests in those without the disease, which you do the math, gets you to 66%. So now we have updated our post-test probability to 66%. We went from 10. We did a test, we got to 30. We did another test, we got to 66. And so now we update our probability again. And so now here's where we are, right? And we can keep doing this until we raise the probability higher and higher. And that's what we want to do, right? We had a 10% chance of the test. We had a positive test, which raised it to 66%. And we know that with our testing characteristic, a high sensitivity increases the number of true positives in the area of patients with disease, right? We want this green area to be big here, and we want this green area to be small here, right? And the green area is people with a positive test. And so high specificity makes this area smaller. So high specificity shrinks the false positive. A high sensitivity increases the true positives. And that's exactly what we want. So we want to test with high sensitivity and high specificity. And that's what this video is all about. It's really talking about a couple of things. Number one, your pretest probability matters. Where you start from matters. If you have a very rare disease, it's going to be unlikely that they have the disease. And the higher your probability, and a positive test means different things. Because if you started off higher, then the probability is going to end up higher. Positive tests is going to increase your probability, and how much so depends on the specificity of the test. And a negative test is going to decrease your probability, and how much so depends on the sensitivity of the test. Okay, that was a lot. Watch it a few times or email me if you have any questions. Thank you. Bye.